Dr. Lighthouse, you are muted.
Thank you. That will probably happen again. So thank you for letting me know. I was saying thank you so much for the invitation and the opportunity to learn with you all today. For our agenda, we're going to start with some introductions, sharing a little bit more about our journeys into integrated care. Next, we'll go into what integrated behavioral health care is, definitions of that, as well as difficulties with defining integrated care and the importance of having evidence research-based measurements of integrated care so we can know that we're implementing services and also being able to demonstrate the value of those services. Then we'll dive into how integrated care can be implemented. We'll consider what this looks like maybe at the sites that we are working in. And I will also share more about our training program here at UTSA. We have trained counselors working in primary care settings, and to share a little bit more about that. Next, we'll look at why this matters, why integrated behavioral health care is important, why our involvement is important, and conclude the session with creating an action plan to reflect on what we have gained today, and also how we can put this into action in our various settings. As far as our learning outcomes, by the end of today, my hope is that we will have a continued conversation about the definition of integrated behavioral health, including different levels or configurations of integrated care delivery. We'll also look at major components of the primary care behavioral health model, which is the framework we use primarily in our training program. And then, so we'll explore our use of that, and then examine why this matters. And we're going to talk about the quintuple aim of healthcare and how integrated behavioral health fits within that, and also look at social determinants of health as a facet of healthcare that integrated services, I believe, are particularly well positioned to address. And then, as mentioned, we will develop our brief action plans. As far as our flow and process for today, I have planned and hope for a workshop that will be active and engaging. We'll have opportunity today to have some breakout room discussions, some independent work. I also invite you all to have our chat be active and share your thoughts or questions. Danielle will be helping kind of monitor that as well. But where we can use this time to engage with each other, to learn about each other's experiences, and walk away with some actionable steps. For the workshop, we will have some handouts that we will be using, and Danielle, I think, is going to share those for us in our chat box if you would like to download or kind of work as we go through. Okay, and so what is coming into the chat box are a PDF with the slides for today, and then there are two handouts, and we can repost them as we use them this morning and afternoon, but a scavenger hunt worksheet as well as our action plan handout. Thank you, Danielle. So continuing into introductions, I wanted to share a little bit with you all about my journey into integrated care, a little bit more about the pitch, which was our first iteration of our HRSA BWET program, which has now expanded to the PEP program. And then we'll conclude this first segment with some time in breakout rooms with each other where we can share a little bit more about ourselves, our kind of journeys in integrated care, and our some of our whys. So as far as my journey into integrated care, I have here a couple of pictures. The top picture is from a family counseling clinic in Virginia that I worked at and really established my clinical background in couples and family counseling. I had the opportunity to work as an intern in this clinic and then later as a co-director. And so on this top left shot, we are doing, I guess, a little family counseling joke, and they did a family sculpt of their dynamics of their cohort. But in working in couples and family counseling, I found out very quickly that I needed to be knowledgeable of the other systems that my clients were a part of. I needed to know first and foremost what was going on in school, making connection with the school counselors, making connection with my clients, their in the community. And so within working in couples and family counseling, I look at that as kind of a start to my integrated care journey professionally, where I started understanding and appreciating the value of working together, the importance of that collaboration. But even before that, and as I was preparing for the presentation, I was thinking about, some of my own experiences in healthcare of maybe going to my doctor and having the experience of maybe being asked about my mental health or not, of maybe wanting to talk to my provider about my mental or behavioral health, but not maybe knowing if there was a space for that or how to do that. I also thought about experiences with my mom who had an illness and, the value that having maybe behavioral health integrated services could have served. And so for me in integrated care, those personal and professional experiences, going back to the kind of professional line of the journey, after I finished in Virginia and at the couples and family counseling clinic, I had the opportunity to move to San Antonio and to join the counseling faculty at UTSA. And while here, I was very interested in trying to reestablish community partnerships and engagement, and started making some connection with our local mental health authority. And they had this big book that they gave me that was related to integrated care. And that was really the first time that I started tapping my foot, into integrated care models, into this world. And that was in 2017. And from there, in 2017, we had the opportunity to apply for a HRSA BWET grant, which is for training and education for behavioral health providers. And at this time, when we were applying, I was starting to go on meetings, at physicians' offices, starting to discuss partnerships. But at that time, my idea of what integrated care was still pretty vague. I was like, okay, you integrate services. That sounds good. Let's do that. And so it really has been a journey of advancing counselors in integrated behavioral health. The major objectives of our project were to train 48 clinical mental health counselors in primary care behavioral health, to also develop site partnerships with primary care offices in our community in San Antonio and rural communities, and also to be able to institutionalize the initiative, which that word always kind of makes me chuckle, but to be able to put scholarship, to put trainings like this forward that can help solidify what integrated behavioral health is, how to train providers in integrated health, and how to really advance the services. Some of the major accomplishments of our project that I wanted to share in the first iteration of our HRSA BWET was we established a 12-hour graduate certificate in integrated behavioral health that our clinical mental health counseling students can earn. In the coursework, there are 2 didactic classes and then 2 internship courses. We also developed new clinical training sites, and for me, this remains one of the most important and valued pieces of this, my engagements in integrated care, in being able to be a part of helping bring behavioral health services to primary care sites or to spaces in the community that before did not have the services. And so that has been really exciting, and also can be challenging if you are developing as you are training too. We also on the program found that it was really important to have a close contact with our site supervisors, that the type of supervision necessary and that fits in a primary care setting is nuanced and has differences than maybe more traditional counseling supervision. And so as part of our program, we bring together the site supervisors quarterly, where they can share experiences on site. We can problem solve, and we share supervision tools and information such as like giving feedback and developmental levels. We've also had the opportunity to host workshops as well. Some of the topics of our workshops have centered on what integrated behavioral health is, how it can be financed, and also working with Latinx clients in primary care settings. We had 46 alumni of our program, some that have gone on to continue work in integrated care, including supervising others working in those settings, and able to deliver quality, free behavioral health services to our communities. And we were fortunate in 2021 from HRSA, we received a continuation of our programming. And in this, we really wanted to build on our successes, and then also be able to expand the providers involved in our program, as well as the integrated settings that we are working in. So our current program, we are still training in primary care, but as well have added integrated school and community placements and additional training tracks. So we, as I mentioned, have clinical mental health counseling students, as well as social work students, psychology students, and we all come together 4 times a year and do interprofessional education with one another. And so it's been really exciting work. And why I love integrated care, I'll just a couple, but is that opportunity, as mentioned, to be a part of bringing services to where clients or patients are, being able to expand our reach, being able to also help destigmatize, hopefully make more routine behavioral health when we think about healthcare. So I thank you all for listening to a little bit about my journey into integrated care. And what I would like to invite for us to do next is to move into a couple of breakout rooms. And within that, if we could introduce ourselves to one another. If you want to have a fun bonus, if you want to, what is it when you have a letter the same? My English is not working that well, but you know, I could be joyful Jessica, dynamic Danielle, if you choose, and share a little bit about your experience in integrated care, if you have had some. I think whatever that is, a little bit about your why, and we can continue to explore that, but why integrated care is important or interesting to you. And then finally, one thing you hope to gain from our workshop today. And so again, we'll introduce ourselves, briefly talk about our experience in integrated care, our why, and hope for the workshop. And Danielle, are you able to assist with setting up the breakout rooms?
Yes.
Wonderful. Let me stop this. We'll put the information about what will be discussed in the breakout rooms in the chat. But you can also take a note of that now or screenshot. We'll take about 10 minutes or so in our breakout rooms, and then we'll come back together. And so let me stop this. And soon you should be receiving an invitation. Before we do that, are there any questions about what we are going to be doing? Awesome, sounds good. Well, when those invitations come, we will move there and look forward to connecting more with one another in that setting.
Jessica?
Yes.
Oh, yes, you can hear me. I just wanted to be sure. So
Yes! Yay! I know you've been working on that. Congratulations, Elsa. I hear you great.
Sorry. No, I don't.
Dr. Lloyd Hazlitt, would you like me to set a timer for us to come back, or how would you prefer that we know when to come back?
Yeah, let's do that. Let's do about 10 minutes and then we'll know when to come back.
Okay.
Okay, our breakout rooms are starting to disintegrate, and we're starting to reintegrate with one another. And so we'll give some space for that. But I wanted to, we've got about 30 more seconds in the breakout rooms. Welcome back, good to see you all. Welcome back. I hope you enjoyed some discussion and connection with one another. I wanted to open now to the open the floor and invite what were some points of connection, or I know we had a short time in the breakout rooms, but what were some of the experiences, whys or hopes that were shared? I'm going to stop sharing the screen so we can see each other and would love to hear some thoughts.
So a connection that Norna and I had made was both of our integrated experience came from the master's program. I was a part of our TexCHIP program whenever I was in the master's program at TAMU-CC, and now she's getting that experience here as well.
Yeah, so seeing that lineage and that continuity and connection, great. Thank you, Melanie.
Well, I found out that some of the people that I was in a room with are actually just here to learn a little bit more about integrated healthcare and don't know a lot about it. And I do. I'm a counselor educator myself, but so I was talking to them about my experiences in an integrated healthcare setting a while back. And so I'm not in one right now. But anyway, they were here to learn, more about what integrated healthcare is. And one of them is working with military. And that was Sandy. And then Jessica is still working on her, I believe, if I understood it correctly, was still working on her master's, but had been encouraged to come to your program to learn more about it. Mm-hmm.
Thank you so much, Catherine. And can I ask, when you were involved in integrated services, what did you find most meaningful about that?
Well, actually, it was integrated healthcare. It was a county program. And so mostly the area I was in was counseling crime victims. And so, but many of them were under case management as well. So it was necessary sometimes to contact the case managers with the client's permission, of course. And then we also in that program, some of them went to a psychiatrist who was affiliated with the county for services and medication. Yeah. Mm-hmm.
Thank you. Thank you for sharing that. So a lot of coordination and collaboration in the client care. Thank you. Mm-hmm. What other points of connection or experiences, whys? Let's continue talking with one another.
Well, in my group, my breakout room, we kind of had a similar situation with someone who was really experienced with doing this type of care, and they actually work really closely with a psychiatrist as well. So I thought that was really cool.
Wonderful. Thank you, Unique, for sharing. Okay, well, thank you all for sharing some of those points of connection. And also in the workshop, we are representing a range of experiences and settings working in integrated care. And so that is exciting, and appreciate you all sharing some points of connection. And that gives us an excellent segue into our next portion of our workshop, where we're going to dive more into what integrated behavioral health care is, looking at definitions. I'm also going to share with you all about the comprehensive healthcare integration framework, or the TCHIP framework, which was recently released by the National Council for Wellbeing, and provides a framework for defining integrated services, and how that can look at different constructs or kind of levels of integration. So when we talk about integrated services, that can range from coordination among providers and collaboration to fully integrated teams. And so the TCHIP framework is helpful in looking at what are important components or domains of integrated practice, and what are benchmarks affiliated with that at different levels of integration. And then we will conclude this portion of the workshop with the scavenger hunt worksheet. Danielle, maybe if you could reshare that in the chat, or if folks want to pull that Word document open, we'll use it at the end, but you may also find it helpful if you wanted to take down some notes. So that's where we're headed. Let's start though, and in the chat, would love to have some dialogue. What words come to mind when we consider integrated care? No right or wrong. What words come to mind? If you could share those in the chat, let's do some brainstorming. Collaboration, team, connectivity, holistic. Resources, one-stop shop, like that, Raven, patient-centered. Equitable care, professional role sharing. Wonderful. Those are very comprehensive, and words too that when I think about integrated care come to mind. And as far, the future, I love that, multidimensional. Thank you. Keep that coming in the chat. But as we can see, when we think about integrated care, there are a lot of words and concepts that can come to mind. And in defining what we mean by integrated services and trying to come up with an operational definition, sometimes we can be talking about a blackberry and a cherry, and we're calling both integrated services, but they're quite different. And so in the definition, wanting something to be broad enough to be inclusive of the variety and diversity of practice settings, but also not too broad where it becomes unclear, what integrated services are versus not, how we practice those. So what are some of the provider competencies that are important to integrated practice? What is important for the team, the whole clinic competencies, and how do we operationalize or name those so clinics can assess their status and plot their growth towards integration. And another difficulty that has been associated with defining integrated care is being able to connect the services to their value in measurable metrics, associated with patient outcomes and lower costs. So translating the power of integrated services, of what that can do for our patients and our broader population into ways that can be fundable. And so when we think about the definition of integrated care or efforts to define integrated care, these are some challenges that can come along. And I wanted to ask you all, what do you see as some potential problems with maybe too broad, maybe not operationalized definitions of integrated care? What might be some problems that could stem from this? Feel free to come into the chat or unmute yourself. Yes, thank you, Elsa. So with different points of view can get lost. Could you say a little bit more about that?
I was saying earlier about one of the good things about integrated care is multidimensional. But also when we lost the focus of what we want to do, we can get lost in these different points of view. I mean, it can work good when we are focused on what we want and everybody works on that and put the efforts towards helping that patient or that group of patients. Or we can get lost in our schools where I'm talking about theoretical schools, the schools that we like or we study, and we can get lost trying to defend one point. And if we stick on that kind of thinking, we can get lost.
Yes.
In an integrated care.
Yes, thank you for that. And I heard that, part of that can be working in silos or trying to break some of those silos, be they like theoretical, this is like how I see things, or being able to, with integration, it's important, but not an automatic process. So just because you have a variety of providers together, I think as Elsa talked about, that it can get lost, or being able to have that collaboration and that transformation across the team, where we are not just unionizing, 5 or 6 different perspectives, but creating a multidimensional, holistic lens of care. Thank you. What other problems or challenges could exist? Norina, I like what you put in the chat, where we can have among the team maybe different definitions of services. And some of the clinics that we've worked with, our interns have talked about, as the behavioral health consultant, an important part of their job is educating about what their role is, about the services that they can provide. Yes, the impact, and yeah, I mean, the problems can be really across the board. They can contribute to diminished patient services or interventions, provider burnout or miscommunications. And so I'm glad to be here with you all and in the workshop in taking a look at definitions of integrated care and how it can be operationalized. What I'd like to show next is a brief video that talks about integrated care and those services. And so we will hopefully do that.
When it comes to healthcare, there are many ways to get care. There are organizations that provide different care for different needs, like primary care centers, ERs, dentists, pharmacies, and behavioral health centers. When you have multiple health issues, you traditionally have to set up multiple appointments with these different specialists. Sometimes people get help for only some of their concerns. When that happens, it's hard to get well. Although certain concerns may seem unrelated, they are all part of a whole person, a system, and it's hard for the person's healthcare provider to help them reach whole health and wellness unless they are aware of and know about all of the concerns. When they know all concerns, they can help the person decide which options for care may be more effective. There's a new approach, integrated healthcare. For people with multiple health concerns, including mental illness and addiction, healthcare providers are adopting integrated care practices. That means they're teaming up with other healthcare providers to increase access to primary and preventative medical care, mental health care, addictions treatment, and sometimes dentistry, offering coordinated care, sometimes even in the same office. Community health centers and behavioral health centers are beginning to work together to provide services as a team and screen and refer people to each other's office for the services needed. A growing number of integrated care providers are in the same building. What does integrated care look like? Let's take a look. Meet Wendy. Wendy doesn't feel well. She has diabetes and bipolar disorder. Lately, Wendy's been sad and drained of energy. Last month, Wendy was in the hospital for complications from her diabetes. Now she needs to refill her medications and wants to see someone about how she's been feeling. She could go to a health clinic to see a doctor or nutritionist for her diabetes, a separate behavioral health center to see a counselor and psychiatrist for her bipolar disorder, and then head over to the pharmacy to pick up her medications. This time, Wendy is going to a place in her neighborhood where she can get primary care, mental health care, and addictions treatment. When Wendy gets to the center, she meets Renita, the receptionist. Renita helps Wendy enroll in the center's care. Wendy tells Renita about how she was just in the hospital, and she tells her why she's come in today. Wendy explains how depressed she feels, how she wants to talk to a counselor, how she needs a psychiatrist for her mental health medication, and a doctor for her diabetes. Renita gives Wendy a screening form where Wendy shares that she drinks heavily but would like to stop. Renita explains to Wendy how at their center, she will have a caring team of professionals all at the same location to help her achieve her health goals. Renita then introduces Wendy to Nathan, the nurse. Nathan takes Wendy's blood sugar and is alarmed at how high it is. Wendy explains that she hasn't checked her blood sugar for a week because she doesn't own a blood sugar monitor and can't afford one. Wendy tells Nathan that she'd like to know how to take better care of herself. Nathan checks with Wendy's health insurance and sets up an appointment for Wendy to see a doctor on that same day. Wendy then sees Dr. Dynamite. Dr. Dynamite gives Wendy a physical, and while she's doing that, Wendy talks with the doctor about her bipolar disorder and diabetes. Dr. Dynamite is concerned about Wendy's worsening symptoms of depression and steps out of the room to call a consultant psychiatric provider who suggests an increase in Wendy's antidepressant medication. She then writes Wendy a new prescription for her diabetes medication and the change recommended by the psychiatric consultant, and suggests that Wendy meet with her colleague Louise to talk more about her bipolar disorder. Dr. Dynamite indicates that she will also talk with Louise about Wendy's diabetes so that everyone is on the same page. She asks Wendy to check in with Nurse Nathan every day that week so they can together monitor her blood sugar. While Wendy is waiting for Louise to come into the exam room, Nathan talks with Wendy about managing her blood sugar, eating right, gives her tips to drink less, and advises her about her medication. Nathan then introduces Wendy to Louise, the center's licensed clinical social worker. Wendy feels comfortable enough to share her experiences and talks with Louise about her recent symptoms. Louise asks Wendy if they can meet on a weekly basis to start. Louise asks Wendy if she'd like to meet with Pia, a peer counselor. Louise explains that peer counselors are individuals on the care team who have experienced getting help for a mental health or addiction concern themselves and are trained in helping people who are working toward recovery just like they have. Wendy agrees that she would like to meet with Pia. Louise also gives Wendy a list of some nearby support groups that can help Wendy reduce her drinking. Nathan, Louise, Dr. Dynamite, and the other professionals that help care for Wendy at the center each know the outcomes of their visits with Wendy in one electronic health record. Before she heads home, Wendy chats with Nathan, who will work with Wendy to ensure she continues receiving regular care. Then there's just one last stop. Wendy stops by the on-site pharmacy to pick up her prescriptions. All of Wendy's new caregivers talk about Wendy's progress in regular morning meetings. Nurse Nathan regularly checks on Wendy to make sure she has what she needs to manage her health and to feel better. Wendy is more confident in talking about her behavioral health and medical issues with Nurse Nathan, peer counselor Pia, and LCSW Louise. They see Wendy regularly to make sure she's feeling better and educate her how diabetes can sometimes worsen feelings of depression. Wendy now checks her blood sugar daily, takes her medication on schedule, and eats carefully. She is drinking less each week and is talking about giving up alcohol altogether. She attends a nutrition class at the center and walks every day to lose weight and to help control her diabetes. Her blood sugar is controlled, and with counseling and support, her symptoms of depression are reduced. Since starting this new integrated care, Wendy hasn't had to visit the emergency room or go into the hospital. Wendy is on her way to wellness.
Okay. Thank you for your attention to that video. And I see, thank you, Unique, Raven, and Dr. I, some feedback on the video and how it provided some good definitions of integrated care or what that could look like following the patient Wendy. I'd like to open up, what did you guys think about the video? What stood out in this, the video that we viewed and in following the patient experience?
Well, I wanted to share, I love how it showed how the services can all be in one place, because so many clients that I know, they struggle with going to their appointments, and if they're referred to other helping professionals, sometimes like they struggle with transportation, or you know, they may have some reservations about going to see a new helping professional, or going through a whole nother process of just getting services, of having to get screened all over. So there's a lot of barriers, and I feel like this video showed how a lot of these barriers can be reduced, having, you know, a place where all these services can be done all inclusively in one location. So I think this can be very helpful, just to see how, you know, we can expand mental health services and primary care services in regions where people just are less likely to access services, especially like in rural areas too, where there are, you know, very limited resources available. If we were able to, you know, offer integrated care services in these regions, I think we'd have more access to care.
Absolutely. Thank you so much. So many important points about accessibility, the kind of one-stop shop. Some of my students talked about it like HEB. You can get everything you need there. And yeah, what were some other standouts from the video?
I really liked the explanation that it gave, because it kind of let me know that I actually have experienced a type of integrated care. I don't know if you've ever, if you guys have ever been to like Baylor Hospital, but in Dallas, like they really try to focus on this type of care. Like if you go to any Baylor in that Metrosplex. I don't know if it's like everywhere, but I just know like from my experience, if you go to any like doctor or emergency room, like any doctor that's in their network can see all of your chart history. So it's really, really important. What I liked about the video is that it looked like you wouldn't have to like pay as much, which is better for the patient because, you know, if they just bring the provider into the room, that's way easier. Because I know with Baylor, the only difference is, you know, if I say, hey, my stomach hurts and I'm in the ER, they're like, okay, well, here's the number to this doctor, you know, go to the second floor, but that's another pay, that's another visit, that's more money. So I'm thinking that integrative care is just really focusing on the patient. It's focusing on like the total wellness of them. And I just feel like that's so important, like to actually focus on what's happening with that person.
Wonderful. Thank you, Unique, for sharing both your personal experiences. And I think too, when I saw the video, I'm like, oh, now when I'm like out in the world, I'm like looking for integrated care like, in different, you know, settings, but, you know, thinking about your own experiences. And then I also heard, again, integrated care is patient-centered, you know, thinking about as the patient, the experience of one, just seeking help, you know, reaching out to a provider for care, having access to care is, you know, a step in itself. And then, you know, from there, being able to have multiple facets of her health heard, it was, and attended to under one roof, and barriers like transportation, barriers like getting time to go to multiple appointments, those are real barriers. And we're gonna, you know, those are things like social determinants of health, you know, and how integrated care, by having that patient-centered lens, by recognizing some of the challenges on the patient of telling our stories multiple times, or like, who's this person, what's this, that it can help relieve that. Follow through on referrals to specialty mental health are really challenging, and a lot of times aren't followed through on. And so as we saw, you know, with the mock patient, Wendy, being able to, you know, while she was there, to speak with that provider as well. Thanks, Unique. What other reactions and thoughts do we have?
Hi, this is Norina. I'll put my video on at the Coastal Bend Wellness Foundation. Seeing the video, I didn't realize how very close my organization is to really being able to make this happen. And my fear is that maybe there's a plan somewhere up above, but it has not been communicated to the organization. But we are doing so much of that integration. And it's interesting that they're growing so fast. And especially with the population of LGBT that we serve, and also low income, the Asian community, the Hispanic community, that we're growing so fast that we can't build the building fast enough. And that just says how big the need is. And being able to grab somebody who's the crisis manager and have that person come into an actual medical visit, because that person is very suicidal and has a plan, the whole 9 yards, and have our crisis manager take them to the hospital and complete that. You know, in that moment, it was so clear to me that we may have saved a life, and that if we had sent them home or said, hey, well, let's get you an appointment with the psychiatrist, but that kind of magic, and it does feel like magic when it comes together, is so powerful. And they could, I think this organization could really pull it off because of the great people that are there. And I hope, I have such great hope for that.
Thank you, Norina. I appreciate that. And I was going to invite, with the comprehensive health integration, or the TCHIP framework that we're going to look at and to share more about. That may be part of the worksheet that was shared was a scavenger hunt meant to think about, in our current settings or in our experiences, kind of where have we seen these aspects of integrated care. But the framework is designed to assist clinics, to assist providers in being able to do an assessment, of their integration, and how to build that. And so I think some useful things, and I appreciate you two sharing, it's like integration is out there, it's happening, we're very close to this, and having a name for it as well. Thank you so much, Narina. Danielle, I see we're having some discussion in the chat. What's going on in our chat box?
Yeah, it looks like a lot of people are echoing what Norena shared. I can kind of see here continued discussion about how a hospital has evolved to really meet the needs of their patients. Unique was continuing to share about the Baylor Hospital system in Dallas, which I got excited about hearing because my mom utilizes that system. And I know it's been really helpful for her to be able to see multiple providers on the same day for different issues that she has going on. So I think that's primarily what was going on, just kind of affirming what others have shared so far.
Wonderful. Thank you for that summary. What other reactions, responses did we have to the video and really to this discussion about integrated care? This is very rich. Thank you for your contributions. What other thoughts do we have?
Something that was kind of salient for me watching the video is that all of the different professions who are involved in integrated care have to value each other. Because if Dr. Dynamite, when seeing Wendy, didn't value, the mental health component, then she wouldn't have reached out and said, hey, I've got this patient here who's struggling with depression. What do I do? And I think that sometimes that's what's lacking in integrated care. So you have the capability, you have the people, you have all of these different resources that patients can use in one location, but it sometimes falls on the providers that they're not bridging those gaps and allowing patients to have access to all these resources. Maybe not intentionally, but sometimes that becomes a barrier for the patient.
Wonderful. Ashley, thank you so much for that perspective. I think, and connecting back in the video where we saw that the providers were knowledgeable of each other's roles and how they could collaborate. And there was that respect for the physicians as well. And in my experience, I've seen that, as you said, it's important, but it's not automatic and it's not intentional, but that's because we need to be intentional sometimes in, being able to, when we are working in team-based settings, to have time to learn about each other's roles and really to transform the practice and how we're thinking about practice. I'd mentioned it's, how I see it, not just 5 or 6 providers together, but really a transformed whole. And thank you for that note. What else?
Well, I had mentioned accessibility earlier, accessibility for clients, but even like accessibility, kind of like what we're saying now, accessibility for other helping professionals, because there have been several times where I've had a client who needed to be seen, who needed to be in front of a psychiatrist, like in that exact moment. And fortunately enough, like that's when the clinic was open, that's when the doctor was in. And so we were able to sit the client in front of the psychiatrist, and it helps mitigate a lot of issues, especially like during a crisis situation. And so, if a client's meeting with me and, they're needing to see a medical specialist, and they're not accessible, that just becomes more of a challenge to the person providing the service, directly to them. So yeah, I saw that as a big benefit.
Thank you for that. And later when we, in the workshop, we're going to examine the quintuple aim of healthcare and how integrated services can assist with that. And one of those aims is surrounding provider well-being and, to being able to foster that collaboration or being able to help alleviate one another's workloads in ways that make sense. As a behavioral health consultant, I see that the patient, is a patient that I'm working with, and I'm also working with the entire team. I'm trying to, with the primary care provider, with the nurses, enhance knowledge of behavioral health overall, or to facilitate that collaboration. And that helps, that helps relieve, I've seen an experience personally and then professionally in our grant. Medical offices move very quickly, and there is a lot of patients that are coming through. And if a patient is experiencing a crisis or has something going on, that the provider, the PCP may not always have time or knowledge to address the patient's concerns. And so we can see how that can contribute to burnout on our end as providers, or how integrated services really help in multiple angles. Really good. What's maybe one or two more thoughts, and then we'll move forward.
Well, I was thinking that just to like kind of echo what other people have said, like I've seen, like in my experience and other people's, like, hearing from what other people are going through, like especially if like the provider has like a standalone facility, and like, they're moving so fast, they don't have enough time to sit there with that patient, they can really miss a lot of stuff. And or you see it where they just refer out, and then that provider refers out, so then it takes way longer to get like that help that you actually need, because there's not that connectivity, there's not that togetherness or those relationships to actually help that patient or client out. So I think like definitely having that network for providers and having it, especially everything consolidated into one place, would be very great.
Yeah, thank you. And I had, thought about two times when I had worked in, I guess, less integrated settings and traditional counseling settings, and clients would share things about, maybe their health conditions, like, I have diabetes, or and that I didn't really know what to do with that at that at that time, or how that was necessarily connected, or how I could how diabetes management has a behavioral health component, and so I appreciated what you shared about sometimes not having that time or the knowledge and missing things, because I think back and I'm like, oh, there's things that now with a more integrated lens, I feel like have a lens to capture things, and before for me felt more segmented. So thank you very much, Unique. Anything else?
Yes, I would like to say that now I understand what is integrated healthcare. The video was excellent explaining that, and I believe that besides what everybody has been saying, and being like a little bit like an echo, I think this service save life, give a real quality healthcare, save money and save time to the patient. But also, when as a clinical psychology, you need to do a diagnosis, one of the first things that we need to take out of our vision is the health, the physical health of the patient. We need to know that how that is working, and is how that might be affecting the mental health. or that disorder, or that possible disorder, or that disorder really didn't exist. What really exists is first other part. And having this integration, it really saves times, help to not misdiagnose somebody from one perspective, one point of view. And I think that's really wonderful. And everything like everything in one package. It sounds like commercial, but it's everything in one package. Yes, and time, mainly time and money for the patients that assist for having this type of care. Thank you.
Thank you so much. So beautifully stated. And what I like about this video is, it's 6 or 7 minutes long. And in that, I think it provides a very comprehensive overview. And so it's something too that I found that can be shared with patients, and educating them about what integrated services, could look like and how those could be assisting. So I think a good psychoeducational tool in that way. Wonderful, good. Let's continue moving
When it comes
forward. So we're going to continue looking at definitions of integrated care, but wanted to call attention to some kind of major resources, developers of policy and research dissemination in this area. One being the Agency for Healthcare Research and Quality. They actually have a specific academy dedicated to advancing practice and research and all things integrated behavioral and primary care. Also the Center of Excellence for Healthcare Solutions, which we'll be looking at their model today. The Collaborative Family Healthcare Association, I'm curious, is anyone familiar with that organization? It was new to me when I entered the world of integrated care, but the Collaborative Family Healthcare Association is a national organization of different family healthcare providers and has a very strong focus and emphasis in integrated services. And so I would say as a professional association to be involved in, if you are interested in integrated care, is a good thing to check out. Not a paid endorser, just a fan. And also HRSA as our grant funder and as a hub in integrated care. So as far as a definition of integrated services, I want to display this and give time to read. So how the Comprehensive Healthcare Integration Framework defines integrated services as services that are in any setting, means the provision and coordination by the treatment team of appropriately matched interventions for both primary health and behavioral health conditions, along with attention to social determinants of health. Those are things that we've mentioned, like transportation, racism, community safety, socioeconomic status. And these services in a setting in which the person is most naturally engaged. So let me stop. What words stand out in this definition? What do you all see in this definition?
I hear naturally engaged, and I think about, how accessible something is.
mute myself. Yeah, unique, naturally engaged. And I think with this, it's wanting to be attentive to those realities of, it's a lot of strain and stress to seek out services in multiple areas or to have the health literacy to navigate those systems. And so going back to the patient-centered focus of integrated services, it says, providing those where our persons are naturally engaged, bringing our services, there when possible. And that leaves kind of flexibility in that for us. Thank you. What else do we see?
This is Norina, and the words that stuck out to me were provision and coordination. And in a previous life, I did systems work for organizations, and I know how much effort needs to be done to make sure all the systems, from the electronic health record to the way that patients are scheduled and the profile of the doctors and the people who can serve that, all of that has to be done well. It has to be managed, and it's not just kind of hope it all works, it's really hard work. And I think that's the part that scares organizations, and the part where they do not have the resources to dedicate to it. But in the beginning, it's absolutely critical that those processes are managed. If not, the back end pays for it all in confusion, delays, wrong medications. I mean, the list could be forever, but a lot of times organizations do not invest in this part of the process, and it absolutely is critical.
I agree with that, Norina. Thank you so much. So that provision, so the direct services, and also that coordination and the challenges that can come with that, and to wanting for it to integrated services to not feel like such a barrier or an add-on to the practice. And so really that coordination of how to integrate that and why we're doing that across the team is critical. Thank you. What else? One thing that stands out to me, in addition to what has been discussed, is interventions that are attentive to both primary health conditions, so things, chronic health conditions like chronic pain, diabetes, asthma, anxiety, and behavioral health conditions. And so being attentive to each of those and knowledgeable about how, for example, I'd mentioned like with diabetes, I may be able to assist in that, with the patient and looking at, what are some of the barriers to taking your blood sugars. In the video, having access to the equipment, or maybe developing a food diary, talking about what it's like to have diabetes, and it's scary, and having that space. And so within integrated services, having that kind of generalist perspective. And then in this, that it specifically names and gives value to the role of social determinants of health. And piggybacking on Ashley's comment in the chat, where we are tailoring and matching our services to the patient and their needs versus vice versa. And so, okay, let's continue forward. Thank you for that. So as had mentioned, but wanted to just re-summarize, some of the barriers to implementing integrated services. Some of what can be hard is lack of flexibility in models or in what we're defining as integrated care. You know, it has to be in a doctor's office, or, you know, it has to have these particular professional roles. That balance of having models that are broad enough, but also that are flexible. Also, deficiencies in measuring integratedness. So talking about providing integrated care or integrated services, but as mentioned, we might be talking about an apple and an orange, and being able to have measures of, you know, this is what integrated practice is. These are the competencies of the provider. For example, you know, integrated providers are accessible. They are educators. And so being able to have, like we're going to look like in the framework, different ways of being able to assess what is important to integration and how do we as an organization, as an individual provider, be able to measure where we're at and to communicate that in metrics that are consistent, and that can be connected to value. One facet, and I'm curious from your all's experience, but in our training grant, in placing students in primary care settings and in behavioral health consultation roles, there was so much positive outcome, you know, to the clinics reported and to the patients, but being able to, for the purposes of value and financing, connect that to lower patient, you know, cost, fewer emergency room visits, more follow-up on treatment, being able to link what we know happens in integrated care to the value of those services. And as is mentioned, as these are innovative and transformational types of services, so too must our healthcare financing, you know, transform to be able to, you know, account for multiple, you know, visits on a day with multiple providers. So what I'm going to share next is more about the comprehensive healthcare integration framework. And Danielle, if you had accessible at some point, if you could maybe share in the chat the full version of the framework. It's about 70 pages, and so a little light reading for you all on the rest of your Saturday and Sunday, but wanted to share that. But I'm going to go over some of the highlights of this. But this framework was just very recently released by the National Council for Wellbeing in April, and sought to bring together previous models and efforts and definitions around integrated care. For example, SAMHSA had defined in the past kind of 6 levels of integration that a clinic could be a part of, kind of across a continuum. But wanting to have a framework that addresses some of the challenges with the flexibility of the model that was mentioned, and also how we can measure that. So the framework was developed to assist us in being able to name and operationalize and measure our integrated services, as well as a clinic, as providers, be able to know how to self-assess and how to advance integration, and to teach our teams about that. So within the framework, and if you wanted to, the scavenger hunt worksheet that was shared earlier has just kind of 8 boxes, and for each of the domains, after we review what each of these are, we're going to have a chance to do some independent work with one another and do kind of a scavenger hunt activity where we think about where we have seen these aspects or domains of integration, maybe what we would like to see more of or what stands out to us. And so within the framework, we're going to go over these 8 domains of integration in more detail, but it talks about in integrated practice and integrated practices, how it is essential to have screening and referral processes, and also where we have processes to help follow up on care and on referrals, having evidence-based treatments, working as a team, a multidisciplinary team, having measurement tools, linking with the community and social determinants of health, and also the financial stability. So we'll dive more into each of those. Within the framework, the CHI framework, they describe what they reference as 3 integration constructs. And these constructs represent kind of different levels or positions of integrated services a clinic may be providing. And so at the first level of screening and enhanced referral, this is where with integrated sites, we have collaboration between providers, we have referral and kind of screening mechanisms in place. And there is integration, but it is not kind of fully on a prime team, but there is a level of collaboration and recognition of interconnection between behavioral health and primary health needs and services. In the second integration construct or kind of level or position of integration, here we have enhanced consultation. And so some of the configurations that you all have shared about where, you know, there's someone on the team that can be brought in for a psychiatry consultation, or where the primary care provider works with a behavioral health consultant, where there are care and consultation among a team. And at the highest or the level 3 of integration, really this is where we have those comprehensive systems, maybe like Baylor. I'm not familiar with all of their ins and outs, but where from start to finish, there is a system in place for integrated services. And also that there's attention to population management. And what that means is considering the health and the services for individual patients, but also looking at, you know, within my community, within the patient profile of this clinic, what are some needs? Is there a need to have more behavioral health screenings universally in the clinic? Is there a maybe consolidated problem that we have around where a lot of our patients, you know, have diabetes? And so maybe we could implement a support group or an education group. And so where we're looking at the individual patient and then also that larger population health. Within the domains, I had shared the 8 I'm gonna come over here to my note sheet, but the 8 domains that the framework talks about, and these are components that are essential to integrated services. And for the first domain, here we have screening, referral, and follow-up to care. And we see that it breaks it down to having both screening processes. So maybe having in place in the clinic where the PHQ-9s, patient health questionnaires, are given, or there's a process to screen for behavioral health services, and then having a facilitation of those referrals, a mechanism in place. And I'm going to read a little bit from my notes. I had these I want to pull up, but the framework defines domain 1 as encompassing steps to develop methods and systems for identifying patients with preventable risk factors for general health and medical conditions in behavioral health settings and risk factors in physical health settings, assessing their symptoms and effectively referring or ensuring engagement in care. And so having screening and referral related to both physical and behavioral health conditions and referral processes in play. The second domain relates to the use of evidence-based interventions and evidence-based protocols. And they define this domain as covering the use of evidence-based guidelines and treatment protocols, including tools for ongoing symptom monitoring and strategies for intensifying treatment for patients who do not show improvement. Workflows are developed to reduce and mitigate general health risk factors such as smoking, alcohol use, and obesity, as well as common disorders such as depression, anxiety, substance use, diabetes, and hypertension, with follow-up mechanisms in place to track patient outcomes. And so here, again, we see within integrated settings having evidence-based protocols that are attentive to chronic health conditions. And so what was mentioned, anxiety and depression, but also things like chronic pain and diabetes, et cetera. Within the third domain, this relates to ongoing care management and that longitudinal engagement and monitoring. And we saw that in the video where with Wendy, when they were showing her with her integrated services, where following her appointment, she had follow-up from her providers in reference to her care, and that there were systems in place for that. For this domain, they talk about ongoing care management as ongoing, proactive, and relentless follow-up of patients is essential to decreasing fragmentation between providers and engaging patients in their care. This domain encompasses the tools for electronically tracking and coordinating information. And then the fourth domain relates to, in addition to evidence-based interventions and services, also that there is attention and integration of tools to promote patient autonomy, activation, and self-management. And so things that the patient can utilize beyond the life of the integrated service treatment period, or as ways to enhance the services. I'm going to stop there real quick. And on these first 4 domains, what are some thoughts about those and why they might be important in an integrated service setting? Oops, sorry about that.
Well, I think self-management support is really important because if we're trying to integrate healthcare, the patient is also part of their own health team. So I think that teaching them and trying to make sure that they're not having those repeat visits, they're actually trying to get optimal health and wellness. I think that's a very unselfish way to actually like help the patient.
Thank you, Unique. I like what you said too about your patient is an essential part of the healthcare team, of their healthcare team. And we saw too in the video and the demonstration of Wendy as she moved through the integrated services, some, involvement of her, what are her important goals, educating her about the services that are available, about the different providers. And it seemed that she left the visit feeling pretty empowered and supported. And so I think that's critical. We talk about as counselors working ourselves out of a job, and similarly, within integrated services and the support that we provide, wanting to promote the patient autonomy and maintenance of their healthcare. Wonderful, thank you. What else stands out?
This is Norina. In the case of a federally qualified health center, which is what my organization is, we're serving a clientele that typically does not have insurance. And so we can't just refer to anybody. And so it's really important that we're able to refer to other LGBT friendly and supportive organizations. It's also important that we're able to refer to organizations that can help with payment and things like that. So understanding that facilitation of the referral process is actually huge. That's one of the things that came up as I was listening to that for me.
Great, thank you so much. And I think as you spoke of having in that referral a network of either in-house or providers that we collaborate with, and then beyond that, having follow through on that referral. Often, and I'm sorry, I don't have the exact statistic, but many of us go to our primary care providers or our doctors, if we're having a behavioral health or mental health, or we don't know what's going on. We may, start with our doctor. And in, traditional settings, one, if our doctor were to hear us, about that, maybe we would be, provided with a referral to a counselor or to, for counseling services. But being able to, there's barriers, that systematically get in the way of being able to, follow up on those referrals. And so even when we have the referral, it's important to have the mechanism and the follow through on that. Great, thank you so much. What else? One other thought I had with the ongoing care management, where we are, again, following up with the patients, and then also kind of looking at the larger population kind of trends for maybe who is engaging in services, who is not, being able to be proactive in also initiating that ongoing care. Wonderful, thank you. So let's move forward into the second half of the domains. And in the fifth domain, this speaks to the multidisciplinary team, both the team itself as well as how information is shared and reviewed across the different integration constructs. We looked at that triangle of the three, from kind of a screening and coordination between providers to fully integrated teams that are sharing electronic health records, that are regularly meeting to discuss patients. And so the framework talks about at different integration levels, you know, what and how that sharing of information looks like, how the team functions. And also the importance of integrated care team training. You all have spoken so well to that, you know, from some of your experiences where we can have providers together, but we may lack knowledge or experience with each other. And so having training specific to our roles, and then also what it means to function as a integrated care team. And so under this domain, they talk about is with patients having dedicated time to improve healthcare. Integrated settings foster multidisciplinary teams that share responsibility for treatment, which includes patients themselves, peers, prescribers, therapists, families, and their caregivers as appropriate. As the care team evolves, changes in workflow are necessary to break down the silos that frequently exist to communicate and exchange information. These changes are not just about breaking down silos, but about adapting clinical and practice identity. Teams often need time to review the management plans and share information, as well as recommend changes to treatment. The sixth domain of integrated systems and is having systematic measures of the services that we provide, as well as ways that we can improve those services. And so one example of this from our project is we noticed that a lot of our behavioral health interns working in primary care settings, a lot of the referrals that they were getting from providers centered on anxiety and depression, and I think things that maybe more easily come to mind when we think of mental health or behavioral health. But as far as referrals for things like, say, a patient with diabetes or a patient coming in with asthma, where the behavioral health consultant could provide some brief intervention or support, that those referrals weren't happening as easily or automatically. And so we used some quality improvement to recognize that, and then we provided some additional training to both the students and the providers about what a behavioral health consultant can do, the range of conditions and ways that they can support patient care. And so it's really important to be able to assess what you're doing, how you're doing it, and what the impacts are of that. And so within this domain, the framework talks about systematic quality improvement is another domain to increasing the capacity and competence. And I think both of those words are important. So the capacity, the number of patients that we can serve, the reach of our integrated services, as well as our competency in that. Being able to show our fidelity to the treatment model, for example. The seventh domain in the CHIEF framework relates to linking with community and social determinants of health. And in the second half of our workshop, we're going to spend more time focusing on social determinants of health. But within this domain, it talks about effective integrated care involves addressing the key social influences and determinants of health along with general health conditions. This domain focuses on steps for fostering effective linkages to housing, vocational and supportive social services, community organizations, and other resources. It deals with addressing and incorporating relevant social determinants and addressing disparities into care plans and helping mitigate the impacts of systemic discrimination. And then in the eighth domain, this pertains to the sustainability, being able to account for and bill for services. And then I had mentioned too, as healthcare transforms, also having expanded processes for regulating, for reimbursing these services, for licensure and training around them. Let's stop here and let's open again. What stands out about these next domains?
Something that stands out for me is the systematic quality improvement. Because I think a lot of times, like when you go to see your primary care doctor, if they're not in integrated healthcare, you just kind of see them and they address your issue and then it's like, okay, transaction done, we're good to go. But in integrated care, like there's a constant reassessment of like, okay, how can we make sure that we're meeting all of the patient's needs? How can we make sure that we're collaborating effectively? And there's just a lot more of that, I guess, patient-centered care is the best way to say it. Like they're really, really focused on how did we not meet your needs and how do we make sure that we do that next time?
Thank you so much. I think that was really well described, and like having that quality improvement where we're looking at, what are we missing, or, maybe before we had where we saw the patient, made the referral, and as, was said, end of transaction. And we didn't really have any way to monitor or assess, what happens after that. Yeah, thank you so much. What else?
As you were talking, Dr. Lloyd Hazlitt, I kind of made a mental connection with something that Norena said earlier about how the back end and the kind of processing side of things is still a pretty integral part of being an integrated site. And I see that under the sustainability category of it's not just a matter of like getting all the members and practitioners on board, but also how are we reporting those outcomes like you had shared earlier, but also how do we make sure that our processing is in sync? And I imagine you probably have to make some changes to make sure that it's all kind of speaking to one another.
Mm-hmm. Absolutely. Thank you. Other thoughts?
I was thinking about the linkage with the community and social determinants of health, that to me, like the first thing I think about is like social workers, because that's usually their domain. But when you're integrating the health, it's like every person, every provider has a distinct role into making sure that this is important. Usually, you know, when you go to the doctor, they're not worrying about like, are you eating? They're just saying, you know, you need to fix what you're eating. But they're not like trying to figure it out. So I just love like how it's making sure that every member is doing their part to make sure that the entire system is functioning at its optimal level.
Thank you.
And excuse me. And to do that, I agree with Unique and everybody else. And I want to say that one thing that we can see is we could possibly lose the individual in a huge system. And I think that every system should incorporate something as a means of trying to prevent dropout in a program. In other words, because we all know in counseling, we have people who don't show up for various reasons. And many times it's the social aspect of it. They miss the bus, or it's raining outside and can't stand at a bus stop, you know, that doesn't have shelter. I mean, we have to think about the personal side of this. It's very important. I mean, we're talking about qualifying a system here, but we can't lose sight of the individual in this. And so that I think would be an important part of the integrated care team training.
Yes, thank you so much for that. And I think that too speaks to even though these domains, there's 8 of them, they're interconnected, you know, themselves as well. I heard Catherine talking about within the integrated care team training, you know, training around the patient, the importance of the patient experience, and how that's something that really stands out to me, like in this model, in this framework, where there is explicit attention and accountability. I believe that is being given to us as providers to be willing and able and accepting of these barriers like transportation, things like being able to get my healthcare equipment, where it's not just, you know, I've given the patient these like to-dos, but then I'm not accounting for, you know, their reality and their abilities or resources. And so within this, there is attention to social determinants of health make a huge difference. And as providers, as clinics, as patients, being able to look at our services and say, you know, where might there be inequities? Where might we be able to maybe strengthen, you know, maybe provide transportation support, or, you know, where are we missing people, and being able to able and willing to transform our systems and services to be accounting for the reality. And so within the domains, I want to be mindful of our time. We are just at about noon. I have a little bit more content for us, and then we're going to take a short break. But I wanted to, continuing with that framework, and Norina, this is where I was referencing might be, you know, kind of an interesting or useful tool to your site or to other sites, but within the framework, it breaks down the different domains. And so, for example, we looked at the domain of screening and referral to practice, describes what this might look like or how it might be approached in a kind of historical, non-integrated practice, and then goes on to at each of those three integration constructs or kind of levels of integration, from screening and enhanced referral, what that looks like. And at each of these levels as it becomes more fully integrated. And so we see at the first screening and enhanced referral level here, this means having some of those screening tools, having the relationships, the referrals, the collaborations, systems in play. But within here, we are in the next level of integration, we add those things as well as capacity for an integrated team. So where we have maybe a behavioral health consultant working alongside the primary care, and then to kind of fully transformed practices. And so within this, we can take a look at our practices at each of the domains and kind of do an assessment of, do we have this in place, or what might this look like? And then, where might our team or clinic be right now in the integration, and what would it look like to increase that? This is another example. So they do this for each of the domains. I wanted to share this one as well. This one relates to the evidence-based practices and protocols for both behavioral health and primary health conditions. And we see as we advance in integration, there is more collaboration and access and shared knowledge between primary health and behavioral health. Medication is prescribed, and there is coordination, and then also at highest levels where there is routine and widespread adoption of trauma-informed lenses and trauma-informed assessment tools that are attentive to factors like social determinants of health, or so with that, this provides a guideline for us to look at these different domains, and then also to have a sense of what this looks like and how this can be measured at different positions of integratedness. What I am going to do for time is in the scavenger hunt worksheet, I want to invite for you all to, we're not going to do a breakout room for that, but to continue to do some work with that on your own or with each other. And within those 8 domains that we examined, to think about not only which one stood out, but from your experience, either personally, professionally, how present or absent have you seen these elements? For example, we talked about some gaps sometimes in referral processes, or talked about maybe how things like transportation, like cost, are maybe attended to in our clinic. And then also anything that you would want to learn more about. Danielle, thank you for resharing that. And let me stop. I wanted to just provide a brief summary of some of what we have covered thus far. And thus far, we have had a chance to do some introductions and share a little bit about our journeys into integrated care. We've talked about the definition of integrated care, as well as challenges to defining that. We just talked about the comprehensive health integration framework, its domains, and the integration constructs, so different kind of levels of integration. And again, with that scavenger hunt worksheet, invite for you all to make note, talk to your colleagues, what are you seeing as far as these? We're going to get ready to move to a short break, but before that, I wanted to ask for any comments or reflections as we close this component. I hope you guys are learning a lot so far. I'm learning a lot and am enjoying. So let's take a 15-minute break. We're going to restart at 12:25, if that works. And we're going to come back and look more at how integrated care can be implemented and why this matters. And so please take a break, stretch, go to the bathroom, jump around, dance, pet your animal, and we will resume at 12:25. Thank
So
you.
you want us to just
Okay, we are at 12:25. I hope you had a good break. We're able to step away. Hope I don't have food in my teeth. And looking forward to the second part of our workshop, and what our business agenda will be for this part is we're going to look more at how integrated care can be implemented, why this matters, and then developing our integrated care action plans. So within how this can be implemented, I am going to share a little bit about the primary care behavioral health model, which is a specific framework for integrated services in primary care settings. And within that kind of triangle of the three integration constructs that we looked at, the primary care behavioral health model kind of falls in the second, where we have a consultant working embedded within a primary care team. So to talk a little bit about this specific model, I'm going to share a little bit from our training curriculum just to give a preview of that. And then we will conclude this segment with taking a look at a mock patient and working in some small groups to talk about how we might work with this patient in an integrated setting. So that is where we're going. And so let's go. With the primary care behavioral health model, I mentioned this is a specific model and framework for integrating services, and really serves as a prime model and a gold star standard in primary care for the integration of services. And I have on here, when we say PCBH, we mean PCBH. And I say that because in our training, having that fidelity or sticking close to the model of primary care behavioral health enabled us to have some measurement of competencies that we could train with our students. Also where we could evaluate sites in their enactment and support them in carrying out the primary care behavioral health model. And so it was really important for us to learn that model and also to teach and train very closely to that. And within that, I'll share a little bit more about that, but as I do, you might hear or feel that some of the roles or positions of a behavioral health consultant, which is the name of the kind of embedded behavioral health provider, be this a psychologist, a counselor, a social worker that is working embedded in the primary care team, and typically work with patients. And so that's different language sometimes for us in our counselor training, using the language of patients in our clinical sites. But within the primary care behavioral health model, they utilize the GATHER acronym to talk about the role of the behavioral health consultant. And so this is something that we train and practice around with our students. And within this model, integrated services and the behavioral health consultant apply a generalist lens. And so when I'm speaking to a generalist lens, talking about seeing patients kind of across the board when they come into their provider, being trained in providing services for behavioral mental health interventions for, say, anxiety and depression, as well as being able to have information and training in chronic health conditions like diabetes, asthma, chronic pain management. So where we as the behavioral health consultant proactively also seek out patients in the schedule that we might be able to assist with. So broadening our lens to be inclusive of physical health and behavioral health conditions. BHCs are also meant to be accessible. And so they are not meant to be in a hallway, down the hallway in a separate room, a separate office. The behavioral health consultant works on the floor and within the rooms with the patients and makes themselves accessible to the providers. We've talked about the innovation of integrated services, and so part of the role of integrated behavioral health consultant is being accessible and demonstrating how services can be beneficial. Within primary care behavioral health, the model is also very team-based. And so the behavioral health consultant, when we train our students, the first weeks of internship are spent on site shadowing every single provider, from the aspect of front desk check-in to how appointments are made, to billing, to medical assistants, to nurses, really being acquainted with the team and going back to being able to address some of those challenges. We need to have knowledge of the facets of our clinic and of the different members of our team, and in valuing each member of our team and their role in integrated services. A BHC considers the client or who they serve to be both the patient as well as the primary care provider. And so seeking to, with the primary care provider, to help reduce or share, workload, to be able to collaborate and to intervene with patients. And so I'm attentive to both the individual patient services and also am team-based, and within the team, providing support and information about behavioral health consultation services. BHCs also tend to be pretty high volume. So within the physician's office, they may see anywhere from 8 to 12 patients, maybe in a day, typically for 20 to 30-minute visits. And so this is a shorter treatment length, as well as a high volume of patients. We are wanting to try to expand and touch as many patients and providers as makes sense and is appropriate, but to have a high volume of patients and to be generating some of that patient load too. A BHC is also an educator, and so that is educating patients through psychoeducation. So what integrated care is, what diabetes is, what self-management is, what breathing techniques could be useful, why our behavioral health makes a difference, what that is, educating patients as well as the primary care team. And we tell our trainees that this education is ongoing. It is not, I arrive to my site, I'm like, hey, I'm the BHC, and everyone knows what that is, and I'm plugged in. It is also educating the team about that role, about integrated services and how we can assist. And then finally, within this model, where behavioral health services are and consultation are a routine part of the practice, where it's routine to have screenings or to make a handoff to the behavioral health consultant. So what I mean by that is if the primary care doctor were meeting with the patient, where it would be a routine part of practice to maybe introduce behavioral health services, to the patient, to make a soft introduction to the BHC. And ultimately, where we are considering more routine, looking at behavioral health, physical health, emotional health, spiritual health, financial health in collaboration. I'm curious, what are you all hearing about the GATHER acronym and the BHC role? What stands out?
Hi, I was thinking, well, it's very difficult to say what stands up, but for me to think about accessible and team-based, it brings most of everything. I think that's like the base of this gather. Accessible, well, the same word describe it, team-based too, but thinking about gather, team-based, it like put everything together. That's what it stands out to me.
Yeah,
Thank you.
Thank you. Yeah, and that accessibility is really important. We've talked about accessibility of services to patients, as well as the accessibility of the behavioral health consultant to patients, to the treatment team, and moving away from maybe more located models where, maybe there is a behavioral health person or a counselor, but they're, down the hall or in a different building, to where that person can be brought in to visits or sessions with patients as they happen. And team-based, to me, that speaks about that transformation that we've, talked about with the just not bringing together of a group, but really in this model working from a team-based lens and developing that together. Thank you. What else? One of the things that stands out to me, or that is often discussed, is that the high volume of patients that can be seen. And the within this model, we may have 20 or 30 minutes with the patient while they're seeing their doctor. And so also, how and what do we do in that 20 to 30 minutes? It's sometimes a shift from our, at least I'll speak for myself, from the idea of a 50-minute, session once a week to in that 20 to 30 minutes, how do I connect with the patient and understand and come to a meaningful goal and intervention that we can provide. And so I always joke with the students, it's not speaking 50 minutes in 20 minutes, but really it is a transformed type of practice. And so in our training curriculum, just briefly, I alluded, we have 2 didactic courses. The first provides an overview of integrated care and of the primary care behavioral health model. And then we also learn about common chronic health conditions. So we look at anxiety, depression, chronic pain, diabetes, asthma, and how as a behavioral health consultant, we can assist. We also have specialized internship sections for these students where they're able to collaborate and consult. And there are a variety of settings in where we place students. Some of the sites that we've worked with had existing integrated services. And for some, this was brand new to them. And so having the internship sections and being able to, one, normalize that clinics have different places of integration, and what that looks like at a site means different things, and being able to provide extra support to the students in say being able to advocate for the services that they can provide as a BHC. I mentioned we also had found having a learning community for our supervisors to be very important. Also in this model, sometimes supervision is provided in kind of a live or fly on the wall type fashion, where the supervisor may do kind of co-visits with the student intern, or the student may conduct a first part of the visit and then step out to consult with their supervisor. And so we provide specialized training and also coaching to the sites. And so going back to the 8 domains of integration, we might examine with a site, where they're having strengths, maybe where there are some limitations, and provide coaching. One of the prime things that we provide coaching around are things like scheduling and rooms. How and where do we help support the site in having that infrastructure that's been talked about, where we can interweave the behavioral health consultant, or being able to identify challenges or barriers that we can help problem solve with the sites, and hopefully, alleviate those challenges as we can, so integrated services don't feel like more trouble than they're worth, because it is a difference to a practice. It is a new way of doing things. I wanted to show a brief video, and in this video, it talks about the core components of a behavioral health consultant visit. So within that 20 to 30 minutes that we have with the patient who maybe has come in to see us or has been referred to us while they were there seeing their provider. And so this video talks about what the different steps of this type of visit looks like. And so we'll take a view of this and then come back with one another. And as a shout out, the person in the video is Dr. Neftali Serrano, and he is the executive director of the Collaborative Family Health Association, which I'd mentioned as a professional organization that does a lot with primary care behavioral health. Let's see what he has to say.
Hi, I'm Dr. Neftali Serrano, and this is the Behavioral Health Consultation Podcast. And today we're going to be taking a few minutes just to review what a basic behavioral health consultation consult looks like. So we're going to kind of work on the anatomy of a typical consult. Before we do that, however, let me just kind of put out there some new news. There'll be some links down in the video notes below of what I'm talking about. There's this exciting new Center for Integrated Care that SAMHSA and HRSA are collaborating on. For those of you who don't know, those are two governmental agencies that oversee a lot of the funding that goes to both community mental health centers, substance abuse treatment centers, and federally qualified health centers. So they've been real driving forces in the integration movement. And obviously things have coalesced to a point where they really feel like they want to be putting out best practices and evidence out there. The website's pretty cool. It's got some good information on it. Has some of the resources they have available for folks needing support, either at clinics or individuals. So good stuff. I'd point you to a particular resource that I found pretty interesting. There's a document by the Milbank Memorial Fund that really puts the range of integration models there side by side and compares and contrasts them across a couple of aspects of the models as far as how integrated they are and some of the barriers that they face specifically. So check that out. Again, the link will be below in the video notes. So let's get right to it then. Let's talk about the core component.
Sorry about that. Let me.
Hi, I'm Dr. I don't have my own patients. That means I work a good job of introducing yourself and the service that you represent. And a typical introduction basically has the following components. Obviously your name, your role, and typically here we use simply behavioral health consultant, a description of that role, and that's a very brief description. Typically I use something like, I work here as part of the medical team, and I work here supporting the primary care providers and their patients. And that means that I don't have my own patients. That means I work with the patients of the physicians here. And then some idea of what that means kind of functionally. And here it's very important to avoid the typical mental health jargon. What I tell patients is I support patients and their providers in a variety of areas. Sometimes it's in helping them make lifestyle changes like eating better or engaging in healthy activities like exercise. and also dealing with things like life stress more productively. So it's in a description, functional description of what we do. Another key important part of the introduction is just timing. You want to set expectation for the pace of the consult, how long it's going to last. So typically I say, typically our consults last anywhere from about 15 to 20 minutes at the most. And that gives the patient kind of an expectation, which helps them understand that they need to be concise in how they work with you. A couple of other quickies, but particularly for a first-time consult. Obviously, introductions differ on the second time. But particularly for a first-time consult, important just to clarify how you communicate in the team. And so we note that we chart in the same area of the chart as their provider would, and we do that so that we have good communication as a team, and that their information is just as confidential as their medical information in that chart. And we let them know that we'll be talking with their provider after the visit's done to communicate the plan that we have in place. So those are some of the core components of a good introduction. One of the first things we do with trainees is actually have them write out an introduction, because it's so easy to get kind of loosey-goosey with introductions. And when that happens, unfortunately, what happens is the rest of the consult can really meander. And in fact, the introduction I've found, or how well folks are doing with the introduction, is also a good indicator of how well the person understands their own role in primary care. So a lot of times folks will struggle with their introduction, and it's really an expression of how they're struggling with what is my role in primary care and how's that different than what I perhaps used to do in specialty care. So it's a good discipline to develop, to get a good introduction down. If you're new at this, I would encourage you, write one down, try it out with patients, then work it out over time. Introductions tend to evolve over time, but they always should have those key core components that we discussed. Now, the final aspect of the introduction is the transitional statement. And this is important because it helps, again, set the pace and tone of the consult. The transitional statement is basically kind of that statement you use to transition from the introduction to the functional analysis. And it doesn't have to be a super great question. It just has to be something that helps set the tone and pace for your consult. And that leads the patient right into the core of what you think you're going to be working on that day. So I usually use information I've gotten from the primary care provider and what the presenting concern was, and use that as part of the functional analysis. So I'll say something like, so I talked with your primary care provider, and they let me know that you've been struggling with some difficulty with sleeping, and that you think this might have to do something with some stress you've had recently in your life. Can you give me a sense of when this started and how much it's impacted your life overall? So a nice, real specific question dives right into the core of the issue. Even if you choose the wrong question, say the patient actually doesn't want to talk about that, they want to talk about something else, you've set a tone for how you want to talk about it. So that severity duration question is often a good one to use for that transitional statement. Leads you right into your functional analysis. What you don't want to do there is, so how can I help you today? That's not going to be an effective kind of question for really setting the pace and tone for your consult. All right, moving along, functional analysis. Functional analysis is essentially what it sounds like. It's an analysis of how the person's functioning. There's more kind of academic definitions for it, obviously, from the behavioral analysis folks. But essentially what it means is you're trying to get to know a person's life around the problem area that they've identified. So you're trying to get a sense, for example, if it's sleep and stress, in the functional analysis, you're trying to get a sense of what they've tried already to kind of work on the issue. You're trying to get a sense of their life routines. So one of the key questions I'll often ask is, walk me through a day in your life. What time do you usually wake up? Do you eat some food? What kind of things do you do as you go through your day? And that gives you a lot of information about all what behaviorists will call behavioral contingencies in their life, but also what ACT folks would call their values, right? So what do you spend the most time on? What's really important to you? Obviously you want to glean a lot of information in that functional analysis about things that may impact mediating factors or causal factors that may impact the specific problem area that you're looking to target. So a good functional analysis would be really the heart and soul of what you are working on with the patient in that visit. Introduction should take you, anywhere from 30 seconds to a minute. Functional analysis really should be the core 10, 12 minutes of your consult. When you do a good functional analysis, pretty much problem formation, problem solving takes care of itself. So the other piece that you're looking for in the functional analysis, aside from kind of the context around their problem, is you're looking for their motivation. So what are the approaches that will likely be most acceptable to that patient at that time? So you're assessing as you go along, asking questions about kind of what has worked, what hasn't worked, what kind of ideas they have about why they're having the difficulty, and how motivated they feel to work on it through a variety of ways. So a patient might tell you, basically in so many words, I basically want medication, and medication is the thing that's going to fix this. That then helps orient you to where you're going to have to work on your problem formation, because then you know that part of what you're going to work on is actually reframing the problem so that you're switching it from a medication-only approach to a more holistic approach. All right, problem formation and problem solving are really go together. But problem formation essentially is how you frame the problem, if you reframe that and say, well, you don't have enough activity during the day, exercise, stimulation, and you don't have some good sleep routines in the evening, then that gives you a very different frame on the problem, which then leads to how you're going to solve that problem. So if you're not together with the patient here with the problem formation, perhaps they may be at an early stage of change, then you're probably not going to have a very robust problem solving or planning section. And that might be okay, for example, if the patient's at a pre-contemplation stage of change or a contemplation stage of change, because you obviously don't want to throw a solution at them that they're not going to be motivated to follow through on. In either case, the big piece here is getting together with the patient, being collaborative about how you frame the problem. And that'll often take the form of a statement, clarifying statement. So it looks like, in addition to medication being in a possible way of approaching this problem, assuming that there's some biological component to the insomnia, we're also seeming to identify that there's some things in your life and life routines, like becoming more active during the day and practicing some sleep hygiene, that actually might be ways of approaching this problem. Does that sound accurate? And that's a good way of kind of engaging the patient collaboratively on that level. And of course, that makes it easy then to do the problem solving and planning portion. What you do additionally here is you're testing for motivation and feasibility. So you'll ask the patient things like, so if we were to say cut out television at night, say by 8 o'clock, do you think that would be a reasonable kind of thing for you to attempt in the next 5 days? That's the kind of questioning and probing that you're trying to do here in this section to make sure that, again, you're both agreeing to the same kinds of things and that the motivation is there to follow through on these things. And then the planning obviously also includes things like follow-up, when, if, and when the patient's going to come back, and what you're going to talk about at that next consult. So obviously not every consult is cookie cutter and kind of ends up being exactly like this, but this is a core framework that you use when you enter into a room and begin to work with the patient. It takes some work, but when you do it correctly, you really don't feel like that 15 to 20 minute consult is a brief, as a lot of people like to call it, consult. It's just a consult and it flows very naturally. Patient feels like they're engaged, listened to, the rapport is built, and you get a lot of really good information. So, core components of a consult. Obviously, you can leave your comments below. You can email me. for Naftali Serrano. Well, not for Naftali Serrano. I am Naftali Serrano for the Primary Care Behavioral Health Consultation Podcast. Thanks for listening and watching. Hi.
Bravo,
Sorry.
This is the Behavioral Health Consultation
Sorry about that.
Podcast. And today we're going to be taking
Dr. Serrano wants to keep talking with us. Thank you, everyone. I'd love to, I think that I'm enjoying in the chat, the comments, and so please continue there, but providing us with a really, and thank you, Danielle, detailed and description of the format and key components of the behavioral health visit. We also heard Dr. Serrano speaking to time a couple different times in the visit, the length of the visit, educating the patient about expectations for that, and the criticality of maintaining time in that. And so moving us forward, I wanted to share with you all, this is an example of a tape script or mock visit that we asked for our students to complete. And within it, we are looking for, as Dr. Serrano talked to, kind of specific steps in the visit, looking for the introduction. And I totally agree with Raven about the importance and the value of creating and writing down an introduction of yourself, putting it on an index card. And I thought it was wise what Dr. Serrano said too, as far as in that introduction, that can be revealing too, as far as our comfort and our understanding of our role within the primary care team, because it can be, it is different than other practice settings for many of us. And so within the training, having really targeted steps for the visit, actions within that, and having time associated with that. And so going through kind of similar to what Dr. Serrano talked about, that introduction to the patient about BHC services. If there was a screener, being able to provide something like that in the mock session, like a PHQ-9 or the GAD as measures of depression and anxiety, for example. And then the heart of the visit really in that contextual interview, the functional interviewing, which is similar in some ways to a biopsychosocial, but more functionally and context focused on the presenting concern. And continuing in the evaluation or in the training of these visits, looking for that conceptualization. Dr. Serrano talked about sort of that summary statement to the patient where we're getting agreement on our understanding of the problem, context. He also mentioned values and motivations surrounding that, and engaging the patient in their, as a member of their healthcare team, in agreement on that, in collaboration of what the problem is and our solutions toward that. And then presenting the treatment options and intervention to the patient. Within our training, we also just briefly, I wanted to mention focus on both the practitioner-based competencies, so the skills of the behavioral health consultant, so being able to identify and treat both behavioral health and primary health, physical health needs, an understanding of the primary care culture. And when I say that, some of the words that come readily to mind to me are that it's very fast paced, that there is guided by the medical model, and the kind of sometimes not a understanding or an integration of behavioral health services, a valuing of that, not always, but understanding the primary care culture and how as a behavioral health consultant, we can fit within that and complement that. Being able to engage our patients and to approach from the whole person care lens that we have mentioned, and looking at our cultural competencies within that. So within looking at the whole person, wanting to take into account their whole personhood, their context, their cultural values, looking at our clinic and our interventions as a whole, you know, for how attentive they are to that whole person care. Being team-based and collaborative, also being very communicative, needing to be proactive and communicating and educating about behavioral health consultation and what those services can do and ways that we can enhance care. And then around professional values of integrated care and attitudes, as we talked about, you know, having that valuing of the team and the members and a shared attitude toward integration. There are also team-based competencies that are critical that we teach and also provide coaching to sites around, but looking at things like workflow and operations. And so are we having a challenge where maybe a provider wants to refer a patient to the behavioral health consultant, but there's not currently a way to note that on the schedule, or finding a exam room that is available, and those type of operational things. Also looking at the team structure and the roles within the team, the different contributions of individual team members, as well as that kind of transformed team and practice culture as a whole. So what I wanted to do next is to share briefly a little bit about a case, and then provide us with some time to talk and work together in breakout rooms for a short period of time, and to consider how we might approach working with Cecilia in an integrated setting. And so a little bit about Cecilia, and this is brief, and so part of what we might talk about in our small groups would be, you know, more information, or in that contextual interview, in that functional analysis, what might be helpful, what might we want to ask about. But Cecilia has come to her doctor, and she is experiencing insomnia. And then as you're talking with her, she also mentions anxiety and stresses. And within a traditional medical setting, maybe what that looks like is a provider talking about supportive counseling services, maybe making a referral to a counselor, and maybe discussing medication options. And in this case, we see that Cecilia making the appointment. The appointment was a few weeks out with her therapist, and she's still really struggling with her insomnia. And so what we're going to be invited to do, and again, Danielle will open up some breakout rooms for us, and we'll take about 10 minutes. I know that's short, but we'll take about 10 minutes for our discussions. And I'd like for you to talk about, what would integrated services with Cecilia look like? How would you like to intervene? What might you like to know more about? Also, what might working with Cecilia look like at different levels of integration? So maybe within a fully integrated team and system, as well as, yes, we can do that, as well as, maybe more of a screening or referral level of integration. And then benefits or challenges. And so, yes, Danielle, thank you for putting the case back into the chat. We'll also pop these discussion questions into the chat for us to have within our groups, and take a couple moments to note them down. But yeah, let's take about 10 minutes to discuss Cecilia, and then we'll come back together. Okay, thank you. And if you need any help with your breakout room invitations, please let us know. We're going to close it. As we're welcoming back folks, looks like we'll be fully joined in the next 20 seconds or so, but I wanted to briefly start just a couple comments about Cecilia for when we come back. I'd love to hear one or two things about what was discussed in the groups. So welcome back. As you guys are coming in, I hope you had a good discussion on Cecilia. I was sharing, I would love to hear from one or two of you all about your discussions. We do want to be brief, but I can't not discuss Cecilia. So what were some one or two things that we can share out from our small group work?
Well, I can share. So we were talking about how a lot of the time mental health issues can impact our physical health issues, and if Cecilia was seeing a medical professional, I'm sure that they would, of course, run all the tests that they need to make sure that to rule out any medical issues that are maybe impacting Cecilia's health and affecting her sleep. But with a lot of the medical professionals too that work in primary care settings where there's an integrated component, they would refer also to mental health professionals who can then do their assessment, and maybe they'll discover that there's some unresolved issues or trauma or just some anxietizing thoughts that prevent her from sleeping, and will help her be able to better manage those symptoms from a counseling or other therapeutic component. And so at the integrated facilities that I've worked at, our medical specialists and our psychiatrists, they respected a lot the roles that counselors had, and before they would even begin to prescribe any medicine, oftentimes they would refer the client to meet first with a counselor and try counseling services to see if they could resolve some of those issues that were initially, reported to them. So that's what's great about an integrated care setting.
Wonderful. Thank you so much, and Dr. I for that. And I think really well explained. And we also heard Dr. Serrano, with the mock visit that he was talking about, but with the patient with insomnia as well, maybe looking at other behaviors like sleep hygiene or stressors that also could be at play. So as we move into the last part of our time together, it has gone by quickly, but want to consider why this matters, and with focus on the quintuple aim of healthcare improvement and also social determinants of health. So as far as the quintuple aim of healthcare improvement, this is something that has been built on over time. In 2007, there was released the triple aim, which was inclusive of the first three that I have in pink, where aims of healthcare improvement are focused on as we've talked about, the individual patient, and then also a lens on overall population health. Also aims of enhancing the patient experience. We had mentioned the client-centered services, looking at ways to integrate that, to identify deficiencies and enhance that experience of care. And then looking to reduce cost of healthcare. In 2017, a fourth aim was added, making it the quadruple aim that brought attention to provider well-being, looking at the really high numbers of burnout and provider unwell-being, and ways that within our healthcare improvement, things like integrated care, we can also be attentive to provider well-being. And then recently, a fifth, making this the quintuple aim, was added, and looking at, in order to really achieve some of the other aims, needing to look at issues of health equity and to enhance the equity of services, looking at aims that don't intentionally include this, some of the gaps that can remain and lead to difficulty achieving the other aims. They're all connected with each other. And so I wanted to show a short video about social determinants of health. I'm curious in the chat if anyone has heard of social determinants of health, or if this is a new concept, any feedback there. But let's take a look at this brief video about social determinants of health and their impact.
One day you're in the mountains walking past a lake and see a fish that's near death. I wonder what's wrong with that fish. On your walk the next day, there's another fish sick and dying. And day after day, as you walk past the lake, there's even more fish that are sick and dying. I thought something was wrong with the fish, but I wonder if something's wrong with the lake. As you travel through the mountains, each lake you come to has the same scene, a lot of fish that are sick and dying. I was focusing on the fish, but now I wonder, is something wrong with the source of the water in that region that is making the fish sick? Maybe it's the groundwater that's feeding the lakes in the area. This analogy, developed by the Racial Equity Institute, illustrates our tendency to tie social problems to individual behaviors and decisions, the sick fish. However, racism and other forms of oppression in our history, systems, structures, and policies are the root causes, the groundwater of these inequalities, the polluted lake. These systems and structures shape the opportunities people have to be healthy and thrive in each community, the jobs available and who has access to them, the quality of schools and how that impacts and influences student success, the access to, affordability, and use of healthcare, the neighborhoods and spaces where people live, work, and play, and the ways people interact with each other in all of those settings, all of which are under the umbrella of the term social determinants of health. These are the kinds of conditions and the environments in which people are born, grow, live, learn, work, and worship that affect health. There are three major ways in which social determinants may affect specific populations. First, differences in exposure. Everyone is vulnerable to stress and environmental toxins. However, certain population groups, because of structural inequalities and racism, experience differences in economics, employment, education, and housing, and may be more likely than others to be exposed to social and physical environments that are harmful, stressful, and compromise their health. For example, people of color and poor people are more likely to live closer to where toxic chemicals are produced, processed, or stored. As a result, a family or entire community can be impacted by unsafe drinking water, polluted air, or other contaminants. Second, differences in vulnerability. A family's ability to fix the source of contamination makes them more vulnerable than other families to health problems. The family may not realize their water is unsafe. When they do, the family and other community members contact the service provider to advocate for resolution, but are offered no options to mitigate the problem. Adults and children in the family may get sick. Third, differences in consequences. Differences in wealth, social standing, connectedness, and other factors can lead to very different outcomes where health issues are concerned. Communities with social networks that do not include policy decision makers may have a harder time making changes and a tougher time escaping the harms that exist in their neighborhoods and workplaces. For a family with higher income and social standing, unsafe water may be a short-term annoyance until they get resolution from the service provider or move to a home with safer water. However, a family with lower income has limited options. This family may have no other option but to remain in their home, identify alternate ways to access safe water, and continue to fight for mitigation for months or even years. Continued exposure to unsafe water and the inability to pay for regular health care or medical treatment will result in severe illness or worse. The difference can result in diminished health for multiple family members, job loss, homelessness, and additional consequences for the children. Social determinants affect us all. The era of COVID spotlights our collective vulnerability and dependence on one another. Our humanity is threatened when one death is treated as a tragedy, while a million deaths are brushed off as a statistic. We have to appreciate the value of everyone's lives. When thinking about social determinants of health, emphasize health equity. Let's think about health equity in a way that's forward-looking, focuses on assets, yet recognizes and accounts for systems and historical injustice. You may often hear the term health inequalities or disparities when it comes to talking about differences in health outcomes. Let's instead shift our focus from disparity to equity. Health equity is the assurance of the conditions needed to be healthy for all people, regardless of identity. Dr. Kamara Jones offers a framework and checklist for identifying equity-minded solutions. Achieving health equity requires valuing all individuals and populations equally, and recognizing and rectifying historical injustices, while also providing the necessary resources according to need. Health disparities will be eliminated when health equity is achieved. To make health equity a reality, we must think critically about the social determinants impacting health. Ask yourself, what are the structural factors that influence the capacity of individuals or populations to reach their full potential for health and well-being? Instead of only looking at the fish, look at the polluted lake and think about the groundwater. Pay attention, be aware of, and create strategies that reach beyond the surface to make the most meaningful steps towards health equity. Learn more about how others are tackling social determinants of health at these resources.
Okay, wonderful. Thank you for your attention to that and some comments. And it looks like Danielle is working on sharing the link for this. I'm glad that it's feels like a useful aid. Again, I want to be brief, but I'd love to open up for one or two comments or reactions to this really important video that we've just viewed.
This is Norina, one of the best I've ever seen on this, and I'm going to recommend that our our safe space training that we give to people in the community as well as to our own employees, that this be added to our curriculum, because it is what we see every day, and it just it's excellent. Just bravo.
Thank you for that. And yeah, I like that it's really user-friendly and really powerful in how it describes. I found the metaphor of the lake to be a really powerful one, and thinking about, you know, how often you know, we can focus on the lake or our you know, I'm sorry, on the fish, you know, versus the lake. And so thank you for that. Maybe one other comment or feedback about the video or about social determinants of health.
Hi, this is Diane Naretto, and I work at a community health center. So we're a federally qualified health center, and one of the things that when I saw this video is that we saw that when COVID first really got bad here, we saw a lot of families that were impacted because they were not able to, you know, quarantine from their loved ones. So we had a few patients whose, you know, several people in their family passed away from COVID or ended up very, very sick, because kind of like a video shows, you know, they can't leave because they can't go somewhere where they have better water. Here, they couldn't even go somewhere to be separate from their loved ones when they had to quarantine.
Thank you, Diane, for that example. And I think that too speaks to, and the video illustrates kind of the cumulative impact of social determinants, you know, over time. And
one day you're in the
there was a reference that I found, and it talked about how, and I've seen some range, but social determinants of health can be unaddressed. And so we're giving our attention to the fish, asking the fish why they don't want to change, or, you know, instead of having our focus on transformation of the metaphorical lakes around us. But that social determinants of health, I think, are an ethical and multicultural imperative for us to attend to. Otherwise, we are perpetuating sort of the fish sick, the sick fish approach to things. And that over time, you know, things that were mentioned, these social determinants of health, like being in access to safe housing, to a safe community, being able to access somewhere to go exercise, the impacts of racism, homophobia, sexism, etc. over time, the cumulative impacts of this, and then adding to that failure to address or to recognize within the healthcare system. And so within the integrated services, within that comprehensive healthcare framework that we've looked at, one of the domains is linking to social determinants of health, to linking to community. And if we are going to be effective, turning our attention to these social factors and important determinants. And so where this leaves us is we are going to use this next period of time. We're going to share or can reshare. We developed a integrated behavioral health action plan. And this is going to provide us with a brief opportunity to do some individual reflection on some of our major takeaways from the workshop today. And then additionally, what supports are needed to advance integration in your settings. And so for this, our plan of action, thank you, Danielle, for sharing that, is would like for us to take about 5 or 10 minutes. We'll kind of monitor and check in, but to each individually take a look at this action plan and to devise some steps and notes for ourselves. And then we will come back together, share briefly, and start our closing for the session. The link should come through the chat. Is anyone having questions or difficulties accessing that? Essentially, we're going to open that and take a little bit of time individually to reflect, to make some notes about next steps, and then we'll come back together. And so let's start with about maybe 5 or 7 minutes on the action plan, and then we'll plan to check back in as a group at about 1:46. Are there any questions before we move into that I can address? Okay, happy planning, and look forward to reconvening in, what did I say? 1:46. Thanks, everyone. Okay, I want to welcome us back, or transition us back from our work on our individual action plans, and would like to open the floor for a little bit of time to hear from each other. We had a chance to reflect on some major takeaways, some goals we might have, and additional supports and resources. So I'm going to stop our fun pineapples here so we can see each other, and would love to hear a little bit from you all about your action plans. Who'd like to come in first? Oh, so I'm not sure. I think you're muted if you're speaking.
Thank you. Sorry. Yeah, on my action plan development, on the first question, my biggest takeaway from this discussion is to think about a holistic service to the patient according to the needs of the patient. That's the most important thing. It's not just giving everything that we have, is what the patient needs. Giving everything what the patient needs. What are some possible goals for myself and my side towards this integrated approach? Is to involve everyone related to the health of the patient. It is like we need to work together. And what support, resources, or information will I need to implement these goals? Well, exactly what we're doing today. Before we started, I didn't know anything about integrated behavioral health, and it is education, and it is educational and what it means integrated healthcare. That will be the first point and for working. And what questions do I still have is about what places in Corpus and Texas that already offer these services. What are the places in Corpus and Texas that already offer these services?
Wonderful. Thank you, Elsa, for getting us started. And thank you for sharing out about your action plan. It seemed like a big takeaway was patient-centered services in the, going back to our definition, in a setting that matches our patients, and with interventions that and treatment team that matches our patients. So thank you so much. And I did make note of your question. Who else would like to come in next and share a little bit about your action plan and takeaways?
So I'll go. I was thinking that my biggest takeaway was really how this operates, especially like efficiently and effectively. I think I didn't know anything about the integrative behavioral healthcare. So coming into this was like a very wide eye opener. And so it was really cool to see how all these components work together for that holistic wellness. Some possible goals that I have for myself in the site that I work at right now. Right now, I'm an intern for the DA office in Nueces County. And what I learned recently was that for the in the juvenile system, they bring in therapy dogs, not just for the actual juvenile delinquents, but also for the witnesses who are testifying, and all of and even the prosecutors, because sometimes they have a very, very stressful job. And honestly, going through this this training, I guess today, it made me realize that there's a lot more moving parts that we could implement to making sure, like even from the prosecutors, that they're not even being, overstressed and overburdened. The prosecutors even have counseling services for them. And so I think even making it like a whole integrative behavioral approach for the entire system, even to the workers itself, I think that would be really, really cool. And I think we're already, even though everything's kind of spread out, I think we're already moving towards having that to be possible. So the resources that I think that I would need would also be, the support from the other services, and actually asking for, those references and referrals for other providers who would feel able and willing to help out. I know that there is a need for the prosecutors to have counseling, but it would just be a lot of like team working to make sure that would be able to be possible. And the only question that I have about it still is, how do you make sure that the providers aren't burnt out? Like, how do you make sure that they can still work together, that they're not worried about pay, or how that, all, because those are important things. And we've noticed during COVID, like physician burnout rate was really, really high. The entire system was really, really overburdened, and the suicide rate for physicians went up too. And I feel like, we're always worried about the patient, but sometimes we need to take care of ourselves as physicians and as providers. So that was my main question.
Thank you for that. And Unique, I was thinking about, coming into this workshop you shared, not really knowing much about integrated health, and now, really feeling inspired or looking in your site as far as integrations that could be helpful, or ways, to transform that team. To your question regarding, burnout, it's not an easy one, but it's a real one. Physician burnout is a major issue. And I think what I found from my experience in working in integrated teams, that we can help relieve, some of that workload, from the physicians, or indirectly, in providing education about behavioral health, about stress management, like say in the form of a lunch and learn, where we can provide that information to the providers for their patients, as well as for themselves, and so some of our students have talked about, on their teams by being approached, by the providers who are having stress, or, sharing some of that information about what burnout is. And so being, able to provide that, support. But I think having two conversations among the team are really, valuable, and, finding where we can hopefully balance each other. Really good question. Yeah. Would someone else be willing to share a little bit about their action plan?
I'll go.
Yes, please come in.
So this action plan involves creating some kind of a meeting with, I'm hoping Dr. I and Ashley and Melanie maybe, and then some of the powers that be at the Coastal Bend Wellness Foundation. I think that they started out like, okay, we'll do this for you, but you just kind of march around with the doctor and have some fun and get your hours, and thanks, you've been nice and it's been good. But I see the potential for so much more, and they could be an amazing site for the university to be able to have our program placed there. And I think they just don't understand what that could really look like. And I could be completely wrong, and they've got some big plan, but I'd love to maybe kind of like a situation where we're educating and supporting and thanking them, and really creating more of a collaborative approach to say, we see you as the potential for really being the premier, services here that is integrated. You've got all the ingredients, and kind of as we used to say in business, greasing the wheels. So that's kind of my action plan.
Wonderful. I can see it happening. And I was saying, too, with that, resources like the CHIEF framework, to the Collaborative Family Healthcare Association, there's a lot for organizations and sites to support their integration efforts. But as you said, having it be going to the importance of having models and definitions, and so we can really maximize what we know is helpful. We see it as helpful. And so thank you so much. I'm going to start to bring us towards our close. Wanted to just give a brief summary of our time in the second half. We looked at how integrated care can be implemented with focus on the PCBH model and that GATHER acronym, and shared a little bit about our training here at UTSA. Then we looked at the quintuple aim of healthcare improvement and social determinants of health, and why integrated care is uniquely positioned to fulfill those aims. And then we ended with our integrated care action plan. I know we have a few minutes left, so I wanted to just open for any questions or comments as we close. Also turn back over to my host with great appreciation for this opportunity to be here, and thank you. Thank you, Danielle, for all of your IT and handouts and conversational support. It made a huge difference. And so I'll stop talking and turn over for any close.
Does anybody have anything that they want to share before I share my closing comments?
Hey, Dr. I, this is Diane. Sorry I joined late, but I just wanted to add, as now I've been with Amistad Community Health Center 4 years, and we haven't integrated with medical and behavioral health model. But some of the biggest, we have the direct referral. I worked closely when I was the director of behavioral health, closely with the primary care providers. But the biggest struggle has always been that workflow issue. When our medical providers are seeing 20 to 25 patients a day, how do we get a behavioral health consultant into the room? And I've consulted with other bigger FQHCs, and it's that workflow issue. Usually it's like, where's the exam room? The doctor's ready to see. How do you time that? And so that's something we continue to work on. But just so you know, this is a great model where, we see the benefits of having the primary care doctor work closely with a therapist and really get the best care as far as comprehensive care for a patient. That's it.
Oh, I had a thought. What if we could all do a best practice journey to Baylor and learn what are they doing over there, and really get some new ideas to bring back to our organizations and see some good stuff in action, and do it as a way to honor that we understand that's what the word on the street is that you guys are doing this right, and we want to do some more of it right. And it would be a great learning excursion and a way for us to also develop our community as well, because we are the change, right? We are the change.
Excellent. I just wanted to say, and then but briefly to that, I'm not sure as familiar with integrated services in Corpus, but I believe, and I'll see if I can follow up with the resource, that there is a directory, or the Collaborative Family Healthcare Association does have some record or locating for that. And so I can, Elsa, to your question earlier, see if I can share that resource. And then, yeah, that's all I wanted to add.
I would say that here in Corpus, the Bayview Behavioral Health Center it's mainly a mental health care facility, definitely, but it does have, with limitations, some integrated healthcare systems set up. In other words, psychiatrists, therapists, administrators, practicing interns all meet together on cases and consult. Yeah.
Thank you for that. And one thing that we do that could be helpful is ask for our students to do, perfect, kind of a scavenger hunt of different hospital systems in San Antonio, different providers, and to look to see if integrated behavioral services are offered, if so, how they're spoken about or described on the website. So wonderful, great. It looks like there's lots of TexCHIP work going on, gathering those resources. So perfect. Okay, were there any other questions that I could take before I turn over to Dr. I want to thank you all again so much for the invitation and opportunity. I learned so much from being here with you all today, and thank you for that. And I will turn over.
Well, if there are no other comments or questions, I just want to thank you so much, Dr. Jessica Lloyd-Hazlitt. I really appreciate all the resources and information that you've given all of us. We're going to take all this back with us too, and better improve our program. We're going to better improve our TexCHIP program and how we prepare counseling students for integrated behavioral health care experiences. And we're gonna definitely beef up what we have going on. So thank you all so much. We learned so much from you and from everyone too who participated. And thank you all for your comments and for sharing your experiences as well. So it's all been very beneficial, and we've been taking some really good notes.
Wonderful. I'm so glad to hear that. I think that our collaboration and integration too is so valuable. And so please stay in touch. The integrated care, we are the change. And so it's fun to change and learn together. So thank you so much. And if there's nothing else, we can end here. Thank you for being here. Thank you. Bye-bye.
If you're wanting to get the NBCC CE hours, I'm putting a link in the chat. And if y'all can just put your first and last names as well as an email address in the chat, that would be great.
Perfect. Thank you so much. All right. Thank you. I'm going to head out. See you all later.
Thank you.
You're welcome. Bye-bye.